We are live on YouTube.
Good morning, everyone.
Good morning, Miss
Good
Virginia.
morning, Miss Virginia.
Morning.
Good morning.
Hi, Virginia. Are you able to have your camera on? Hello.
All right, it's showtime.
Okay, sorry, I'm letting people in.
Good afternoon, everyone. Welcome to our Black Angels Book Club event. My name is Dr. Danielle McCamey. I'm the founder, CEO, and president of DNPs of Color. And I'm just so excited to welcome you to today's session, which you are in for a treat. But first, I just want to share that the reason why we're here is because of Virginia's charge that she charged us to ensure that every nurse across the globe hears the story of the Black Angels and has a copy of the book in their hands. And the second charge was to ensure that that individuals that have an interest in nursing, that they be afforded an opportunity. So we as an organization have put together a scholarship, which we'll put in the link for any nurse or any individual that's interested in nursing will have the opportunity to apply for the scholarship to pursue nursing. So before we get started, I just wanted to give a note of thanks to one of our donors, future doc, Shantae Harris. She so graciously donated so that everyone that wanted to have a book has one. So those that received it in the mail, thank future doc Harris. I see her in the building. Hey.
Doctor, I've conferred.
Yeah. Okay, Dr. Harris, let's go, baby. Awesome. And then also just want to thank our co-sponsors of the event. One of the major organizers, Nurses You Should Know, we have one of the co-founders here, Dr. Joanna Seltzer here. Also want to give a special thanks to the National Commission to Address Racism in Nursing, the Johns Hopkins School of Nursing, specifically the Black Student Nurses Association, the National Black Nurses Association, University of Maryland School of Nursing. Their dean, Dean Yvette Conyers, is here. Thank you so much for being a partner in this work with us. The Black Nurse Collaborative, the Association of Black Nursing Faculty, and Coppin State Helene Fould School of Nursing. Thank you all for collaborating so that we can make this event possible. And without further ado, I'd like to introduce Maria Smilios, who is the author of the Black Angels book. Maria.
Hi, everyone. Thank you. Welcome back. And for those who are first joining us, welcome. Today, we have a wonderful presentation from Dr. Carole Mitnick. I had the pleasure of doing a number of events with Dr. Mitnick, who I met last year during the high-level TB meeting at the United Nations, where she had arranged this wonderful author panel with 3 other authors. And then we've done a few events after. Dr. Mitnick is at Harvard University. She's a professor of global health and social medicine. She has worked on improving care and access for multi-resistant tuberculosis, and she works closely with Partners in Health. She's been to Peru, Haiti, the Congo, and South Africa, but most of her work has been in Peru on and off since 2000. And so without any further ado, I'm going to turn it over to Dr. Mitnick, who's going to give a wonderful presentation on tuberculosis.
Thanks so much, Maria, and thank you, everyone. I had the privilege of joining a couple of the sessions, and I've just found the discussions to be really inspiring and sort of magical to have all these nurses from very different career paths and eras join the conversation. So thank you so much for the opportunity to be able to join you. I am going to share my screen. move into presentation mode, and hopefully that works and you can see. So I'm going to talk a little bit about where we are today with tuberculosis. I'm going to start with a very brief overview of the burden of tuberculosis today, and particularly highlight the disparities that are really the legacy of colonialism and racism that have persisted for centuries, extractive practices, exploitation. We see all this in the way TB is distributed around the world. I'm going to go very briefly through the evolution of TB treatment and preventive therapy since the time that you were introduced to in Maria's book, with the advent of isoniazid and streptomycin, and then take a little pause on where we are today with TB treatment and opportunities for much improved care, but again, the maldistribution of those opportunities. And I'll spend a few minutes talking about how nurses are really the foundation of TB care in much of the world. They play just a huge number of roles and are so important in that space. And then I'll wrap up so that people aren't feeling too despairing after my discussion of where we are with the burden of TB, with some opportunities for involvement directly in TB activities and also in kind of supportive activities. And then I look forward to hearing more from you all, questions and learning from your comments. So this is a figure of the global burden of tuberculosis disease in terms of the numbers of new cases reported. So every year, it's kind of similar to reporting to the CDC here in countries around the world. The number of cases that are diagnosed is reported, and then that information gets shared with the World Health Organization, which in turn produces a report annually on on tuberculosis in the world. So you can see that since 2010, the number of cases notified each year has ranged from just under 6 million to almost 7.5 million cases in 2022, which is the last year for which data have been compiled and reported. You see this big dip between 2019 and then starting to go back up in 2021 due to the pandemic. In addition to that dip in reporting, there were huge disruptions in TB services, with hospitals being closed, with lockdowns precluding people seeking care, and therefore more transmission as people were left with untreated TB for longer. And the estimates are also that probably increased the number of deaths due to TB, again, because of the absence of timely access to care by about 500,000 people during the period of 2020 to 2022. And I want to highlight that in this same time period, every year, we estimate that 30 to 40% of new cases of TB don't ever get even diagnosed and reported and treated. So there's still a very large gap. This second figure is deaths due to TB, and you can see that there has been a gradual or had been a gradual decline in TB mortality, a little more pronounced among people living with HIV, which was a very important advance given how devastating TB had been to people living with HIV. But with antiretroviral therapy in more of the world and being received earlier and earlier in the course of HIV infection, mortality has declined, but we are not doing as good of a job in averting deaths from TB in people without HIV. This map, every year WHO reproduces something like this that just gives you a sense of the relative burden. This is by incidence of cases per 100,000 population. So it takes into account the populations, and basically the darker the country, the higher the incidence of TB. You can see that the highest burdens are really in South and Southeast Asia. Can you see my cursor? Sorry, I always forget how to. Yeah, you can see my cursor. Okay. In South and Southeast Asia, and then also in Africa, which respectively have 46% and 23% of the burden of those more than 6 million or more than 7 million cases reported in 2022. The estimates, the quality of the estimates, are also unequally distributed in that the way estimates get improved is by doing prevalence studies, which are gigantic undertakings. And those are happening less frequently in low-income countries. And so our estimates in Africa and Southeast Asia are probably a lot worse than our estimates in other places. And every time a prevalence study is done, or virtually every time a prevalence study is done, we realize that we're way underestimating. The World Health Organization every 5 years lists 30 countries that are considered high TB burden countries, and that can be based on the absolute number of cases or based on the incidence. So while you see, for example, here, you can see these two countries. So this is the Central African Republic, and this is Gabon. You can see that these both have more than 500 cases of TB per 100,000 population in the country. Some of the other very high burden countries include, say, India, where the burden is, or the incidence is in the 100 to 299 range. But because the population of India is so large, it leads to it becoming a high burden country. HIV, diabetes, malnutrition, substance use disorders are all risk factors on the individual level for acquiring TB and also having poor outcomes. And many of these can also be demonstrated to be kind of ecological risk factors too. So these two charts just show you, in this case, the inverse relationship between per capita gross domestic product and TB incidence. So the higher the GDP, the lower the incidence. And in contrast with undernourishment, the higher the proportion of population that is suffering from undernourishment, the higher the burden of TB disease. So again, highlighting that inequality that I mentioned at the very beginning, and that really is a lasting legacy of colonialism and the institutions that were left in place. Focusing on drug-resistant TB a little bit, which is the area where I do most of my research. So this alphabet soup is for multi-drug resistant or rifampin-resistant TB, meaning TB caused by organisms that are resistant to the most important first-line anti-TB drugs. So of the 10 million or so new TB cases estimated to occur every year, only about 20% are actually tested for resistance. So the others of those that are treated, they're treated blindly without any information about whether they're getting the right regimen or not. We estimate that about 500,000 people each year are newly fall sick with these forms of MDR or rifampin-resistant TB. And of them, only about a third receive what would be considered proper treatment. And of those, of the total burden of about 500,000 each year, only about 14% can be expected to be cured because of the kind of the failure of the whole cascade, the failure to be screened, the failure to be diagnosed, the failure to be treated, and then the poor quality treatment that we had for so many years. So this is one of the subgroups of TB that where there are really kind of major issues. And again, you can see that the global burden of TB is quite maldistributed as well, with disproportionate burdens in low-income countries and also in the former Soviet Union, where the burden of TB is relatively low, but the burden of resistance among those with TB is quite high. Just another way of looking at this issue of disparity, the 30 high burden countries high burden for drug-resistant TB are here classified by their World Bank income classification. So the World Bank every year classifies each country, its eligibility for loans primarily as high income, upper middle income, low middle income, and low income. And more than 70% of the high burden MDR countries fall into the low, middle, and low income country, whereas all of the resources for treating TB, for diagnosing TB, for innovation are in the other two categories. And you can see that no high income countries fall into this group of having a high burden of MDR TB. So this figure, and I am going to share the slides, so you'll have them as a resource if you want to think about this in a little more time than I'm allowing today. This figure is just intended to give you a sense of the evolution of TB treatment from the time that you just read about when streptomycin and isoniazid were first identified as treatments for TB, and how it evolved to multi-drug treatments through the 1950s. Those treatments were 12 to 24 months, usually around 18 months. And then by the 70s, with the advent of rifampin, which is now a keystone of standard treatment for drug-susceptible TB, treatment could be shortened to 9 months. And then when pyrazinamide was added in the 1970s, it could be further shortened to 6 months. And so we went really from, those trials ended in the late 70s, early 80s. We went from the 80s until very recently without any new classes of anti-TB drugs. So this rifapentine outlier, this is the same, it's a member of the same class as rifampin. So then in what we did see, there were a couple of drug classes that were developed for totally different indications, other bacteria, the fluoroquinolones and the oxazolidinones, that were brought into care for TB in the 90s and aughts, particularly for drug-resistant TB, because the choices were so dreadful. And we saw our first new anti-tuberculosis drug class of drugs in 50 years with bedaquiline, which received marketing authorization from the FDA in 2012. Another new class followed suit in Europe. It has not been authorized for use in the US yet. In 2013, delaminid, and then a member of the same class as delaminid was authorized for use in the US in 2019, but only within combination. And all of these are being used for drug-resistant TB to date. So here's just a figure that was produced by our awesome activist colleagues at the Treatment Action Group in New York and the what we call the 146x24 campaign, which is really trying to highlight the amazing innovations. After we had this drought of 50 years, we've had these amazing innovations. And I'm going to show you in a sec how few people are getting access to them. But this is just a summary to show on the right side is what treatment looked like prior to 2016. And on the left side are the innovations we've had. And in short order, there are huge advances in preventive therapy, going from 6 months was the minimum before 2016 to now being able to treat in as little as 1 month. The treatment of kind of run-of-the-mill drug-susceptible TB has gone from treatable in 6 months to now treatable in 4 months. Treatment of drug-resistant TB from 18 to 24 months that included a daily injection for 6 to 9 months can now be treated in most people in 6 to 9 months, et cetera. So we have these amazing improvements. The problem is that nobody's getting them. As Maria alluded to the United Nations high-level meeting on TB that occurred last year in 2023, the first ever meeting was in 2018. And it's really, in some ways it's kind of pageantry it's very far from the reality of the problem, but the idea is really to generate political will and kind of to try to start to hold governments accountable for doing more to fight the greatest infectious killer of adults. And You can see this. I'm going to show you 3 of these little donuts. I don't know what else to call them. I call them donuts. The United Nations set a target for the treatment of TB in adults and children of 40 million people between 2018 and 2022. And I created this second donut around them because I wanted to show that the target is really only a relatively small proportion of probably the number of cases that needed treatment during that time. And I think a reasonable guess is there were probably about 100 million people who needed TB treatment, both all of those, 10 million new cases each year, plus the backlog of people who aren't getting treated is probably more like 70 to 100 million. So they set a target of 40 million, and only 26.3 of those 40 million were treated, 65% of the target, and maybe something like a quarter of the actual prevalent cases of TB. Similar for children, the target was 1.9, the target was 3.5 million. My guess of prevalence is somewhere more like 12 million, and 1.9 million were actually treated during that time period, 54% of the target or 16% of the true burden of disease. And then for drug-resistant TB, it's even worse, that of the 5 million prevalent cases during that 5-year period, they aimed for treating 1.5 million, and just under 700,000 were actually treated. So we have these new tools, but again, their ability to access them is constrained by the way resources are currently distributed and built on a legacy of inequality in the world. I'm going to make a big leap now, a big pivot to how nurses fit into this picture, because they're so important to TB care and to research, again, as demonstrated in the Black Angels. I think I just want to try to communicate how important the role is of nurses around the world in TB treatment. And all my photos are from Peru. As Maria said, it's the place that I've worked most extensively. This is a nurse named Karina who works in the public system in a primary health center, in the TB program in a primary health center. And she is really the linchpin to care for hundreds of patients every year with drug-susceptible TB, and another probably scores of patients with drug-resistant TB each year. And she is really the primary provider of care. She sees patients nearly every day. In much of the world, people have to come into a health facility every single day. They get treated outpatient, but they have to come in every day to get their treatment, because unfortunately, we don't really trust TB patients to take their treatment. It's maybe something we want to talk about. It kind of linked to the stigma that comes across so clearly, and I know is one of the themes for the discussion. There are doctors at the facilities, but patients generally only see the doctors tops once a month, and so most of their care management and first line of response to toxicity events is the nurses. The second photo is a nurse named Jose, who works for the non-governmental organization with which I work really closely, Socios en Salud in Peru. And he's actually, this is a study visit during a randomized controlled trial of new treatments for drug-resistant TB. And so nurses, like in the Black Angels, are responsible for the very, very rigorous, meticulous data collection in clinical trials, as well as providing the treatment support and just being the kind of rock for patients with TB. This image is of 2 community health workers in Peru who are carrying mobile X-ray equipment. And I can tell you that I picked up the smaller of those 2 backpacks last time I was in Peru and put it on my back, and I almost fell over. I think it weighs about 50 pounds, and they go up into the hills, into the urban informal settlements in Lima to do X-ray campaigns. And they are supervised by nurses. So nurses have this they have individual patient responsibilities, they have management responsibilities, they have kind of programmatic responsibilities. And this is a photo of, unfortunately, the late Edith Alarcón, who was somebody who also had very high-level administrative responsibilities, being a senior advisor to the director of the National TB Program, being a leader of one of the main tuberculosis professional societies in Peru, and really kind of a hero for people who work in TB and people with TB. And then this last one is a nurse, another nurse for socios named Lorena. And this is a snapshot from a film called Bending the Arc, which is about the NGO Partners in Health. And Lorena is here really coaching a young man to complete his treatment for drug-resistant TB, despite the toxicities and challenges. Thinking about opportunities for nurses, both in and out of the clinic, I just want to start with this image from a paper in the journal Social Science and Medicine, which is kind of a conceptual framework for how cycles of mistrust can be disrupted. And again, thinking back to the stigma, thinking back to the fact that we often don't trust people with TB to complete treatment on their own. Many people with TB have other social challenges. They may have substance use disorders that creates this sense of mistrust, often from providers. And then in turn, the patients can't trust the providers if the providers don't trust them. So I think one of the spaces for nurses and for really any healthcare providers is trying to meet patients wherever they are and really helping them complete treatment, helping perhaps families be encouraged to have contact screening done based on the specific circumstances and from a human, from the perspective of a human connection, and that all people deserve to be treated for TB and to be treated with respect and dignity. And then this is my last slide, which is just thinking about a few other opportunities for people on the call, or really anybody who might be interested in getting more involved in TB. I meant to ask and I completely forgot, so I'm going to do it right now. Sorry. If there's any chance people could either raise their thumbs or put in the chat. I had really just two questions for you. One, if you learned about TB in school, and whether that's nursing school, or even if you're not a nurse, if you learned about TB in any other context. And two, whether you've had any, let's start with the one so that I can see responses, because I had meant to ask that earlier and flaked. Okay, so we've got a few people, but not a lot saying that TB was part of their education, which is not terribly surprising, but really unfortunate. And my second question is whether you've had any contact with TB, any direct contact, whether that's in your clinical practice, in your personal lives, just anything. Has anybody treated TB or had family members with TB? So again, a few. Okay. So I got some advocates here on the call. Excellent. I really look forward to hearing more about your experiences. So this is just one of the opportunities I wanted to mention. There are several groups like this one called We Are TB that are really groups to try to support people who are living with TB, people who are diagnosed with TB and understandably quite frightened by that experience, and to kind of help make common cause with them, help reduce the stigma they might be facing, or help them develop strategies for managing whatever else is making it difficult for them. Another opportunity is some advocacy work. The author and YouTube sensation, John Green, has gotten very involved in advocacy around TB in the last year, around specifically trying to persuade Johnson & Johnson to not enforce secondary patents on this relatively new anti-TB drug, bedaquiline, so that it will be more affordable, and more recently on reducing the price of really key cartridge bridges for the diagnosis of TB, and that's called the Time for 5 campaign. And I'm hoping these QR codes work. This is the first time I've ever tried it to put QR codes in a presentation, but I'm hoping they work. These are all open opportunities. Anybody could get involved in either. And then the other thing I wanted to highlight, I mentioned to Maria when we spoke earlier this week that I was on a call about a new call for proposals that NIH released last month, which is really focused on trying to change the structural conditions that allow diseases like TB and other diseases with major disparities, trying to undermine the conditions that allow those disparities to persist. And I'm happy to report that it's the National Institute of Nursing Research that is leading this call. Other institutes are also involved in accepting proposals, but this is their kind of framework. This is how the National Institute of Nursing Research looks at a framework for improving health. And it's a much more comprehensive, much more kind of structural oriented framework than most of the other NIH institutes, which tend to be very reductionist, like looking at molecular mechanisms of disease. So really excited about that and excited to be on a call with a group of people. With a group of people who are steeped in this kind of tradition. And with that, I will stop. Thank you.
Thank you so much, Dr. Mitnick. Apologize for the sun that's coming in.
Sorry for you, Joanna.
No, it's fine. I really, really appreciate you being here today to spell everything out. And I'd love if anybody on the call wants to come off mute or enter into the chat any questions for Dr. Mitnick. I do have two. I'm happy to start off. One is about the issue you mentioned with that people test for TB, but then they don't test for the resistance. Can you just articulate a little bit about, is it just one of those things where anything that takes more than one step in healthcare just doesn't happen? Or, is it like, what's going on? That seems like such a critical piece of the puzzle once you do get diagnosed to know whether or not your strain is resistant to the traditional treatment.
Yeah, thanks, Joanna. That's a really good question. I think there are several answers to it. One is kind of the culture of work in TB globally, and it has been a culture of making do with what we have and not expecting for and demanding better. And so the conventional diagnostic has been smear microscopy since the 1890s, since Koch first isolated the causative organism of TB. And there has been very, very slow uptake of these modern diagnostics that allow you to test both for the presence of the bacterium and the resistance to that bacterium. The resistance to drugs of the bacterium. The second reason relates to this Time for 5 campaign, and that as these new diagnostics have come out, they're expensive and they are not prioritized except for maybe some high-risk groups. And so most people with TB, despite the fact that this Cepheid expert technology has been out since the early teens, like 2010, 2012, it's still less than half the cases get tested with this tool that could tell you within 4 hours whether you have TB and whether your TB is resistant, at least to rifampin.
So the cost is prohibitive.
So the cost has really limited access.
And then just a follow-up presentation, a follow-up question is, it sounds, and that you touched on this, the kind of colonial component that goes on and has kind of overshadowed a lot of Oh, wow. Lori is saying that her institution no longer screens for TB in New York City. So I did want to touch in, and Lori, feel free to come off mute and tell us, share about your experience a little bit. And yeah, Mindy, I agree with you. Like, because, usually you'll do a culture and a sensitivity together, like with a urine, right, to see if you have a UTI. So we're like, as nurses, we're like immediately going into problem solving mode right now. Like, we heard the problem and we're like, well, how can we just like kill two birds with one stone and get the right testing done? But I'd love to understand, because of your depth of knowledge in this space, and I'm happy to, I'll throw a couple of additional links for everyone in the chat, this connection between nursing and colonialism, because I feel like when you say things like, well, right now we can't do best practice because the cost is prohibitive, it sounds very colonialist, where certain care is reserved for certain people. And so I just want to draw that connection specifically within nursing, specifically around Nightingale, specifically around our profession. And then, you can kind of fill in how that has impacted, TB care on a kind of global level. Because you're saying that the standard of treatment from 1890s, which is still very much a colonial era, seems to be, over 100 years later, like what we've been doing all along without evolving.
Yeah, I mean, I wanna touch on this briefly. This could be, a very, very lengthy conversation, but because I also want to hear about other people's experiences, because I think everybody probably has their own lived experiences with some of these legacies as well. And I guess what I'll just do is amplify what you said, Joanna, that this is there are double standards. There is a sense that that people who happen to have the good fortune of having been born in a high income country, or somehow having made it to a high income country, are much more likely to get all of the screening required, and a range of supportive services that are necessary to successful completion of TB treatment. While people who have the different situation of having been born in a low-income country are basically just subjected to an inferior set of expectations about the diagnostic tools that will be available, about the treatment, about the supportive services that will be available. And it is a continuation of kind of extractive practices, while for many years it was exclusively like minerals and plants that were extracted, and now we're extracting labor. Now we're taking doctors and nurses and other trained individuals from from lower income settings, and partially it's because the opportunities for them are better in the U.S. and Europe. Nurses in particular are migrating in large numbers because they can make so much more money. But this is really disruptive to the well-being of people living in lower income countries. And the models of development of, saying, well, we'll give you 5 years of funding and your TB problem's got to be solved by then, but are just completely disconnected from the hundreds of years of extraction of people, extraction of resources. In the development model, that's just not really generally acknowledged. There is some movement towards a quote unquote decolonization of global health, but we've got a long way to go. I see there's a hand up.
Hi, my name is Brianna Patterson. I'm from Rochester, New York. Thank you so much for this presentation. I'm a nurse practitioner resident, and my question is regarding the resistance and like testing for it. So is it the responsibility of the provider to order the specific testing, or is it the responsibility of the health department to order that testing to figure out what resistance and what treatment will be best?
There was somebody who responded to my first questions about saying that they actually work in TB. So I would love for that person to answer your question, because I'm much less well-versed on TB in the US.
That was Dr. Fuller.
It would be the health department that would take over the care of the patient, because it's a reportable disease. And at that point, it is time for us to protect the community and the public. So it will be all through the public health department, wherever that person lives. And we oftentimes work with the local health department, will work with the state, whichever state that individual works in, and then everything is covered. We pay for it all. We pay for the treatment, all the testing. And we are the ones that will oftentimes be the one that go to the home and provide the direct care and all those other things. So yes, it is the health department that will take over the care of that patient. So definitely hand them over.
Thank you.
Yeah, thanks for that. I noticed there was also a question, Joanna, you mentioned it in the chat, just kind of about the technical side of resistance testing, and I can, again, touch on that briefly. So I mentioned the Expert cartridge, which is a rapid molecular test, and you don't have to wait for culture. The advantage to that is that I didn't get at all into the biology of TB, but it is an excruciatingly slow-growing organism. And so it takes 6 to 8 weeks to culture TB faster in kind of newer liquid media. So 6 weeks is what you need to confirm the absence of Mycobacterium tuberculosis. And then to do a phenotypic DST, then you have to start that clock all over again. You've confirmed the presence of TB, then you have to, put it in plates or tubes with the antibiotics to see to which, in the presence of which it's able to grow. So that's why the advent of molecular resistance testing was so important for TB, to be able to cut down from like 12 weeks to 4 hours, at least for a limited number of drugs, as a way to start. But yes, phenotypic DST is still really important for TB, especially for the drugs for which we really don't know what mutations are associated with resistance.
There's a question from
Go ahead, Maria.
from the YouTube audience. Thank you for the great presentation. What is the prevalence of TB in people with diabetes?
I have to confess that I don't know the exact answer to that question. What I can tell you is that there are lots of studies that demonstrate a much higher prevalence of TB among people with diabetes. I don't know if it's 2 times, 5 times, 10 times, and also really importantly, more worse treatment outcomes of people who have diabetes as a comorbidity when they're getting TB. And those worse outcomes can be not responding, microbiologically to treatment. It can also be toxicity, because there can be a lot of overlapping toxicity between TB treatment and diabetes treatment, or between TB treatment and diabetes itself. I apologize for not having the exact figure for you.
There's also a comment just from YouTube audience. Thank you very much for the presentation. Community health nurse in Ghana, TB screening is part of the job duties, but very grateful. And other comments to Dr. Fuller, would not be surprised if there were higher numbers, especially uncontrolled, due to inability to fight infection. A question from Ms. Smiley. Since Peru is a developing country, are they still using iron lungs for treatment?
I have never come across that. My understanding was that iron lungs were more commonly used for polio. I don't know, Maria, if you've come across iron lungs used as treatment for TB as well.
At CVU Hospital, they have these. Well, it's a space that it's called a museum, but it's a space where there's different rooms where they have stuff from Seaview. Like the room is a room for it's a kind of redo of a children's ward. I forgot what it's called. The name eluded me when you remodel something so it looks like something else. What is it? Anyway, there's a crib and there is an iron lung, and Miss Virginia can speak to that because it's this tiny little iron lung, and she's talked to me about it previously when we had done an interview. So would you like to talk about that, Miss Virginia?
Yes, that Emerson, excuse me, that Emerson, it's called an Emerson inhaler, not if a respirator, was used for the polio patients who also had tuberculosis. But it's used mainly for polio patients. And they were very few.
That was the only time in all of my research that I ever came across an iron lung being used for tuberculosis was at Seaview. But nowhere else did it talk about an iron lung being used for TB specifically.
Another question from the YouTube audience. What is the TB prevalence of sickle cell patients?
That's a super interesting question. I think there is not a ton of evidence on the overlap between those two conditions. My guess is that as people with sickle cell live longer, we will see a lot more overlap than historically. But I don't think that like I've never heard about sickle cell as being a particular risk factor for either acquiring TB or poor outcomes in the same way as like HIV and diabetes and treatment for cancer can all really affect the immune system's ability to suppress infection. I don't know if anybody on the call has more knowledge on this than I do.
Thank you. One more question right now. Do we differentiate between diabetes as a primary illness or secondary to TB, similar to what we do with hypertension, essential or secondary?
So again, super interesting, and I'd love to hear the view of clinicians on the call. I am not a clinician. I can't remember if Maria offered that caveat. My training is in public health and epidemiology. One of the things that there is more and more really interesting information coming out that there's a lot of just general dysglycemia with TB. And so people who do not have carry a diagnosis of diabetes may have hyperglycemia at the time of a diagnosis. And oftentimes that just resolves with treatment. But I don't know the answer to this particular question about kind of the sequencing of TB and diabetes. Anybody with clinical experience to speak to that?
Well, we can table that for future discussion. Maria, I don't know if you want to pivot and move towards some of the questions specific to the book at this time. We have 12 minutes remaining.
Sure. I want to open it up if anybody wants to talk about anything that they read in the book, what struck you in this part of the story. I know the guiding question had to do with Missouri and her experience on the ward with the POW. And I'll just open it up and say, what struck you about that? Where do you see some of the themes that Dr. Mitnick was talking about, inequality, and not only in the experience that she had, but also we can talk about the inequality of streptomycin. So if anybody wants to comment on it, or if there are any questions, or open it up for discussion, let's think about it. I guess I can just ask, was it surprising, that story about the POW? Did people know that Black nurses had been tasked to take care of prisoners of war during World War II?
I did not know. I haven't gotten that far in the book. I am just blown away. Sometimes when I read 2 or 3 pages and I have to stop and breathe and take it all in.
Yeah, it's pretty, or I mean, if people want to talk about the stuff beforehand, doesn't necessarily have to be this reading right now. You can talk about anything that struck you earlier if you haven't gotten a chance to get up to that section. So I'm, open to, if it's anybody have questions for me or Miss Virginia or anyone else. Oh, somebody wrote, what came to mind for me was the workplace violence issues that we see today. Do you want to say something about that? That's
Miss McCray.
Yeah, Miss McCray.
Yeah, good afternoon. Yes, no, I was just thinking, just with the verbal abuse and spitting, it just reminded me of some of the common workplace violence issues we see today. And so it was just intriguing for me to think just and reflect that, this has been going on for quite some time, but we're finally addressing some of those issues, or at least trying to, in our current environment.
There's a comment by Dr. Lynch. She says, I appreciate how the nurses treated them like humans despite their monster ways. And that's an interesting comment, because the truth is they didn't have a choice. It wasn't just that it was their professional duty to treat these patients despite the fact that they got violent, whether it was an emotional abuse or an actual physical abuse. If these nurses left, they would quit their job and they wouldn't have anywhere to go. They would leave, and if they got hired, they would start off, if they're all their seniority, they would start off at the bottom of the ladder, not only in terms of where they were in their career, but in pay. And so that was a really big problem. They were kind of stuck in where at Seaview, and they had to do their job. So, yeah, I mean,
Maria, Dr. Mitnick has her hand up.
oh, go ahead.
Yeah, thanks. I just wanted to, I guess, bring both the point made about the violence that medical providers still experience today, and the example of caring for the POW, to kind of circle it back to the conceptual framework on trust that I showed you, and just the discussion about how we don't expect good things from people with TB. Our whole model of care, this whole directly observed treatment model, is really that TB patients can't be trusted to take their own treatment, and in a way that in my experience, but again, I defer to the clinicians on the call, is really unique to TB, that we don't do that with people who have other either infectious or non-communicable diseases. And I'm just wondering about your thoughts, kind of what room is there for improvement in the mutual respect between patients and the system. I'm thinking particularly about TB patients, but maybe you want to speak to other ideas.
Was that to me?
It's to anybody,
Oh.
really.
Does anybody want to respond to that before I do? So I think one of the things that, and again, I'm not a clinician, but just from the research in the book, TB started out as a stigmatizing disease. It was the bacteria had
Hi,
been.
it's Mary Ellen. So I'm on the call. I hope
Was somebody talking, or was that an echo from
I
me?
think that was an accident.
Oh.
Keep going, Maria.
Oh, so one of the things that, when New York decided to build Seaview, when Herman Biggs decided that he needed a hospital to put these, quote, immoral and uncouth and uncultured TB patients at Seaview, one of the arguments was that what he did was he racialized the bacteria. And he said it is African Americans and it is all of these immigrants who are poisoning the rest of our city. And the truth was, African Americans were dying at 3 times the rate of white people. And so what he did was he used that and he brought it to city officials, and then he got Seaview built. So the disease from the outset had been a disease of stigma, of being ostracized. People, it was also the dawning of germ theory. People did not know how you caught the disease. And I don't know, maybe somebody else can speak to that more than I can, but as you see the decades keep going, that stigma doesn't go away. And one of the trial patients that I had tracked down, who you'll meet in the 5th part of the book, had carried the secret. And this was a story that was pretty, kind of terrifying. I have Dr. Robichek's trial records with the names of all of the patients. And when I was researching the book, I started cold calling to see if anybody was still alive. And I cold called this woman, Milagros Delfas, and she answered the phone. And I said to her, I have your name as part of a trial. And she hung up the phone. She was almost 90 at the time. And I called back and she hung up again. And the 3rd time I called, her daughter answered. And she said, what is this about? And I said, your mom was part of this trial. And she was like, let me call you back in a few days. And a few days later, she calls me and she's like, okay, my mother, and Milagros had come from Puerto Rico, had carried this shame for 70 years. She had not told anybody in her family. And she said to me, please do not use my name in the book, because I'm afraid that my friends are still going to think that I'm still contagious. That is how potent and powerful the stigma was. And hearing it from somebody who carried this around well into her, she died, she passed at 92, and she eventually came to closure with it and said to me, you can use my name in the book, that's fine. But I just wanted to highlight how deeply embedded in the fabric of somebody's being that stigma was, hearing it firsthand from somebody. So I don't know how that translates now in the United States clinically, but it started from way back when they decided to use the microbe as this kind of, to racialize it. So historically,
yeah, there's like a racialization, but there's also, like Mary Ellen put in the chat, there's also a policing. There's a policing element to it, of having to directly observe people take medicine. There's a lot of, to go back to Dr. Mitnick's point about colonization and that piece of it, to combine the stigma plus the policing on top of it, really. And then also that there are innovations in care that are cost prohibitive from the people that have the highest incidences.
The policing also goes back to in the beginning with Biggs. He started sending all of these nurses into the homes, and then he wanted them to report the names of all of the patients to him. And he made this disease map, and doctors and nurses were outraged because they felt it violated patients' rights. And he did not care about that. And so the policing began again because they were not able, in his eyes, to take care, or not able to isolate or do anything by themselves. And so it goes way, way back. There's a history of it. Obviously, like Dr. Mitnick said, it's colonialism. Medical colonialism is really what it is.
Yeah, and the persistence of it, I think, is one of the things that really strikes me. So you take HIV as another highly stigmatized infectious disease. And the policing was certainly an early approach, the blaming, the marginalization, the what we would call doxing today. All of that was really common with HIV, but nobody's making people do antiretroviral therapy under direct observation. Nobody, and I I'm not really sure why we persist in TB. It's true, TB is airborne and HIV is not. But it's an interesting phenomenon that requires more interrogation and what the gains are. I think part of it does come back to what I said earlier about the fact that we had so little progress in TB for so long, and there was a sense that we had to make do with what we had in TB, and we couldn't risk making things worse. And the idea has always been to protect the drugs because we never know when and if we'll get new drugs. But still, it's like it seems like a disproportionate emphasis on the drugs than on humans and their dignity and their ability to live their lives.
So it's two. I want to thank Dr. Mitnick and everyone else for showing up. We will post a question for next week. Joanna, can you just remind me what we're doing this time? We're going to post a question, and then what was it, a thought? We call it a thought question. You want to explain the kind of?
I think we're working it out. So we will definitely be in touch, via email, via LinkedIn. It's really just this idea that as you're reading, it's like allows you to kind of have a through line to the present day context. Because one of the things that I really learned is when I first met Maria last year, and Miss Virginia Allen at the DMPs of Color conference, I had been spending all of this time being a nurse in the present day, right? And all of the things that I read in Maria's book completely correlated. But Maria didn't know that because she's not a nurse in the present day in the way that we are. And it's been an education for her as well, for me to explain, no, but these things are still happening. No, but these things are still happening. No, but these things are still happening. Because she was so focused on the research in 1930s, 1940s. She didn't know that there is a commission to address racism in nursing and all of the things that are going on. And so I think that that's where the value is us as nursing professionals to have something that's so well researched and really being able to have that mirror. So we will continue to kind of have some guiding questions that come out as you read, and read at whatever pace. It's definitely a dense book, as Willa mentioned, but even if you're still reading it, into the spring, it's worth it to really acquire that information. And Virginia, is there anything that you would like to leave to all of the nurses that are on the call today?
Let's keep up the good work. I'm looking forward to next week.
Excellent. Thank you so much, Miss Virginia. Also, special shout out to our Zoom moderators, Dr. Yvette Conyers and Melissa. I don't know if Melissa is still here with us on. And also, thank you to you for spending your Saturdays with us. So we will see you next Saturday, same time, same Zoom place and YouTube place. Please share widely with your networks that you were here and invite them to join us next week. Thank you all and enjoy the rest of your Saturday. Take care. Happy reading.